Is it this? He will be speaking on outline on the management of BPH. A brief introduction by our secretary.
Dr. BASIL is alumni of Alapura Medical College and he completed DNB surgery from Nagarkot Jayashekhar Hospital and MCH Urology from Stanley Medical College, Chennai, and currently working as consultant urology at CHAITHANYA Urology and UROGYNAECOLOGY Speciality Hospital. I invite Dr. BASIL.
Thank you so much, sir, for the kind introduction. Respected senior doctors and media colleagues, good evening. Today, planning to speak up on a very common topic, which most of us are dealing with on a day-to-day basis. So it won't be a high-end discussion. It will be just a brushing up of what we all know, and just highlighting on the latest recommendations of management of benign prostatic hyperplasia. So before going to the topic per se, I would like to just run you through common scenarios where the patient presents. The first one is a 40-year-old male with a history of urolithiasis presenting with a reduced urine flow and straining to void for 3 months. Second, a 40-year-old male with 1 week history of increased urinary frequency and urgency. Third, a 60-year-old man presenting with increased frequency of urination with unsatisfactory urinary flow. Fourth, a 60-year-old male presented with acute retention of urine. Fifth, a 60-year-old male presenting with urinary incontinence with no history of abdominal pain and investigations revealing renal failure. And the last, a 75-year-old male presenting with recurrent hematuria associated with BASIL. So, in all these scenarios, we should just think about whether or not we should point to all these causes towards prostate, and it shouldn't be the prostate. And for that, in terminology is come up, which is the lower urinary tract symptoms, and it can be divided into storage, overloading, and post-maturation symptoms. And the storage symptoms include urinary frequency, urgency, and nocturia. The voiding symptoms include hesitancy, straining to void, poor stream, intermittency, and sense of incomplete void, and the post-maturation dribble. So, whenever a patient comes to us, we should actually categorize the patients based on the history. And before going to conclude the reason as prostate, we should just see which of all these symptoms which are all there in the patient. So the initial understanding of LUTS, even the guidelines pointed the cause of LUTS towards prostate, and it was categorized into microscopic BPH, macroscopic BPH, and clinical BPH. And now the understanding is LUTS is not a specific for benign prostatic hyperplasia, and other factors are of equal importance. Now coming to the other causes which can cause lower urinary tract symptoms, it can be a distal ureteric stone, a bladder tumor, a ureteral stricture, prostatitis, even foreign body in the bladder or the urethra, even a UTI or a neurogenic bladder dysfunction, reduced or underactivity, nocturnal polyuria or overactive bladder. So, in order to categorize as to towards which severity the patient has symptoms, there are many symptoms for which has come up, and the most prominent one is the International Prostate Symptom Score, which is used to categorize patients into 3 categories: mild, moderate, and severe. The mild is taken from 1 to 7 points, and from 8 to 19 points, it is categorized as moderate, and from 20 to 35 points, it is categorized as severe. So what are the components of the IPS scoring system? Is all that what we discussed in the first slide, which is voiding symptoms, obstructive symptoms, and the post-maturation symptoms. All these are given 5 points each, and all the 7 parameters are taken into account. And the minimum score is 0, and the maximum score is 35. So, as per the 2022 EAU recommendations, they are recommending to use a validated scoring symptom score questionnaire, including both and quality of life assessment during the assessment of male LUTs. And when we look into BPH, almost 40% of men in the 5th decade and 90% in the 9th decade has some form of LUTs due to BPH. And the microscopic changes of prostate seems to coexist silently with other bladder or kidney malfunctions in some men. And the current EA guidelines has modified the title to reflect the changes in perspective from former LUTs suggestive of BPH to male LUTs, including BPH. And when a patient comes to us, the first step that we do is a history taking, and the history taking itself can give us about 80% clue as to what we are looking at. And along with the duration of symptoms, we are asking for the storage symptoms, voiding symptoms, and post-maturation dribble, and the change in symptoms over time if the patient is on treatment. And previous urological history like persistent or recurrent UTI, interlinked catheter, or any previous urological surgeries, and whether the patient is on any treatment. And second thing which we usually don't do is a bladder diary. And bladder diary is a note given to the patient, and the patient is supposed to note down the time and volume of each void. And this is of most comes in handy when the patient is complaining mostly of nocturia or predominant storage symptoms. And lifestyle modification is suggested as an initial tool if more than 1/3 of the urine output occurs at night. And the guidelines strongly recommend for the usage of bladder diaries. Now, coming to physical examination, there is nothing special except for the importance of rectal examination in a patient who is coming with LUTs. The sphincter tone has to be accurately assessed, and the size of the prostate can be assessed to a largest extent with the digital rectal examination. And along with the size, the consistency, contour, and any change of induration can also be noticed. And the EAU guidelines recommends physical examination, complete physical examination for every patient who is coming with LUTs. Now the question is whether or not we should send a urine analysis for every patient who is coming with LUTs. And the guidelines are towards sending urine routine examination or microscopy for all patients who are coming with any form of lower urinary tract symptoms. And this will help out to rule out urinary tract infections, any hematuria or diabetes mellitus. And if any abnormal findings are detected, further tests are recommended as per the requirements. And now the most controversial thing, whether PSA should be sent for all the patients. And it's still a controversy. And if with the history, we are able to focus that the cause of the LUTs is due to prostate, it is justifiable in sending a PSA to for all the patients who have the primary cause of the symptom as prostate. And how does PSA help this? The PSA would give an idea as to what is the volume of the prostate and whether the prostate has any kind of malignancy. And for approximate age-specific criteria for detecting men with prostate glands exceeding 40 ml, more than 1.6 for men in 50s, more than 2 for men in 60s, and more than 2.3 for men above 70 years. And the pros and cons of requesting for a prostate-specific antigen should be discussed with the patient, because any abnormal value, or maybe like values more than 4, 5, or 10, can cause false alarms and can guide the patient into extensive investigations on the suspicion of malignancy. So it should be a patient-driven investigation and not a doctor-driven investigation. So before sending PSA for a patient, we should always discuss with the patient as to why the test is done, and if it is if the lifespan of the patient is like less than 5 or 10 years, it is not suggested to send a PSA. So when you look at the summary of evidence, the PSA measurement should be done if the diagnosis of prostate cancer will change the management, and measure PSA if it assists in the treatment and or decision-making process. Second thing is, if the patient comes with above symptoms, should be sent for an RFT. Routine RFT, renal function test, is not required unless and until if the patient has clinical findings suggestive of renal impairment, or if there is hydronephrosis, or if the patient is planned for a surgical treatment. Otherwise, the routine examination of renal function test is not required in a case of patient present with LUTS. And if the patient has LUTS associated with hypertension or diabetes, the other indications you can send, but just for the sake of LUTS, the renal function measurement is not required. And the other thing is post-forward residue urine. It is a very important parameter for us, at least as a urologist. PVR give us a lot of information about the function of the bladder and the bladder outflow obstruction and any myogenic failure, which is which can be the reason for the LUTS. And even though the recommendations are weak to measure PVR in patients with LUTS, we routinely do as an extension of extension of clinical examination. And uroflowmetry is just a measurement of the rate of urine flow, and it is suggested in a patient with obstructive lower urinary tract symptoms, which includes strain toward poor stream and sense of incomplete bladder emptying. If the patient complains of any of these, it is advisable to suggest uroflowmetry. Otherwise, on a routine basis, it is not advised. Now coming to ultrasound of the KV. Again, ultrasound of the KV is a weak recommendation as per the AAU 2022. But since ultrasound is widely available, it is a very cheap and non-invasive investigation. It gives a lot of information regarding as to what is the bladder status, what is the status of the kidney, and the volume of the prostate. So it is usually suggested when the patient comes for review with the recurrent symptoms. And regarding transrectal ultrasound of the prostate or transabdominal ultrasound of the prostate, transrectal ultrasound is not usually done because of the minimal invasiveness of the scan and the unavailability of the scan. But transabdominal ultrasound gives a fair detail as to the size of prostate and there is any intravesical enlargement of the prostate. And usually we suggest transrectal ultrasound only in a case we suspect a prostatic malignancy or an abscess. Then coming to cystoscopy, whether or not it is required, the indications of cystoscopy in a patients who are coming with LUTS include microscopic or gross hematuria, a suspicion of urethral stricture, or a bladder cancer. There are no other indications whether you should ask for a cystoscopy for a patient who is coming with LUTS. Now coming to urodynamics, it is an invasive study which is a pressure flow study of the bladder of the filling phase and the voiding phase. It is not usually recommended with in any patient with LUTS unless until we are not able to differentiate between whether the LUTS is due to the myogenic failure of the detrusor or due to the bladder outflow obstruction. So only in these cases we ask for a urodynamic study. Otherwise, it is not usually recommended. So again, the guidelines also says do not offer non-invasive tests as an alternative pressure flow studies for diagnosing bladder outflow obstruction. So what it means is like you cannot replace just the uroflow alone for urodynamic study. If it is indicated, you have to. So just for an outline, when the patient comes with a LUTS, you have taken the history, you have done the physical examination, and the symptom score questionnaire is given and the PSA is done. And if there is any abnormality with the PSA or abnormal digital rectal examination, then directly the patient has to get evaluated for the any prostate malignancy. And if it is not there, and if the post-void residue is very significant, we then ask for a complete ultrasound of the kidneys and the renal function test. And if the patient does not have any much of both of the symptoms, we suggest a watchful treatment. But if the symptoms are very bothersome, then we ask for a frequency volume chart, and then the management, whether it is surgical or conservative, is taken as per further steps. So coming to the management, there are three basic categories. We can actually observe the patient. We can start on pharmacological therapy, and we can subject the patient to surgery. So what are the indications for watchful waiting? So watchful waiting is like we have the IPS score of less than 7. It's a small prostate gland of less than 30 grams, and the bother is so minimal, and the adverse effects of the drugs can upset the quality of life. Then we can subject the patient to watchful waiting. And in this, we advise the patient to reduce or completely cut off the alcohol or the caffeine intake, and just control the urge if whenever the urge occurs, and if the patient is able to overcome the urge once, then the duration of the frequency will gradually come down, and it takes time, and the appropriate counseling has to be done to the patient for it to be successful. Now, second is the medical management. Anything which is not appropriate for watchful waiting or a indication for surgery, all that group of people goes to the medical management. So I'll just outline the indications for surgery. The refractory urinary retention with failed trial work, renal insufficiency due to bladder outlet obstruction, recurrent UTI, then persistent gross hematuria, bladder stones due to bladder outlet obstruction, and also bladder diverticulum. Then failure of medical management like cost and complaints of chronic medication the patient is not able to bear, unsatisfied with medical management, and unacceptable side effects of the medical management. Now, coming to the medical therapy, there are two groups of drugs which are usually used. One is alpha blocker, and second is 5-alpha reductase inhibitors, and third is a combination of these two. So alpha blockers are nowadays we are using the very selective alpha-1 blocker, which is specific to the prostate and the muscles of the prostate. And usage of alpha blockers like tamsulosin, alpha-6 silodosin can cause a reduction of IPSS from 4 to. It can reduce IPSS from 4 to 7, and it can cause an improvement of peak flow rate from almost 1.9 to 2.5 ml per second. But it does not have any role in prostate volume or the PSA, and it does not alter the natural history of the benign prostatic hyperplasia. Now, coming to the efficacy of 5-alpha reductase inhibitors in BPH, we have mainly two drugs, which is finasteride and the dutasteride. And when you see the RCTs, the volume changes are more prominent with the dutasteride, which is almost reduced by 26% when compared to 18% in finasteride, and IPSS reduction is almost by minus 4.5, and the Qmax improvement is almost by 2.2. It is with 5-alpha reductase inhibitors alone, and the acute urinary retention risk reduction is almost 57%, with the usage of BPH, and the surgery risk reduction is almost 48 to 55%. This is with the use of either finasteride or dutasteride alone. So when you combine both of this, the efficacy is all more high, but at the same time the complications are all also high. So when you compare the usual, when you see the usual side effects of the drugs, the common ones are the erectile dysfunction, which is common with both alpha blocker and 5-alpha reductase inhibitors, and then the dizziness, postural hypotension, asthenia, decreased libido, which is there with the 5-alpha reductase inhibitors, and abnormal ejaculatory dysfunction, which is there with the selective alpha blockers. So when you want to medically manage, this is a flow chart. We are seeing whether the patient has bothersome symptoms or not. The symptoms are not very bothersome and the IPS is less than 7. We subject the patient for to watchful waiting. And if the symptoms are very bothersome and if the patient does not have nocturnal polyuria and the symptoms are more towards obstructive symptoms, then we see the volume of the prostate, and if it is less than 40 cc, we subject them for alpha blockers alone and observe for at least 2 to 3 months. If the IPS score reduction is prominent, we continue them on our alpha blockers, and if it is not satisfactory, we add on with 5-alpha reductase inhibitors or anti-muscarinic drugs. If it is more than 40 cc in the initial setting, since 5-alpha reductase inhibitors has a role for reducing the size of prostate to at least 30% over the course of 6 months, we start them on a combination therapy of alpha blockers with 5-alpha reductase inhibitors, and then observe for 2 months, and then follow up with further drugs. If the patient has complaint, then continue with the drugs. If the patient has irritative LUTS as well, we can add on with anti-muscarinic drugs or beta-3 agonist. And if it is not compliant with any of this, then we'll have to subject the patient to surgery. Now, coming to the predictors of progression with the medical management, the baseline variables are prostatic volume more than 30 cc, PSA more than 1.4 gram, increasing age, IPS is moderate to severe, impacts of less than 12, and increased PVR. These are the baseline variables. If it is there, the success with the medical management is questionable, but we cannot say for sure it won't succeed. But still, it can 50%, at least 50 to 60% of the patient can progress with medical management. And when you come to dynamic variables on treatment, when you subject a patient to conservative management, if the IPS worsens with more than 4 score and worsening of PVR, that is subjective serial elevation in the PVR, and even a single episode of acute urinary retention and poor response to treatment, these are the dynamic variables where we'll have to think of referring the patient to a urologist. Now, see one more slide regarding factors predicting poor outcome with medical therapy, which is age more than 65 years and large prostate volume more than 30 cc, increased PSA more than 1.5, high PVR, baseline LUTS IPS is more than 7, and peak flow rate less than 12, and intravesical proportion more than 1 centimeter, which is a grade 3 intravesical proportion of the median lobe of the prostate. Surgical indications, as I already said, is a refractory urinary retention, renal insufficiency, recurrent UTI, persistent gross hematuria, bladder stones or bladder diverticulum due to bladder outflow obstruction, and failed medical management. And when you think of surgery, always the surgeries of prostate are complicated because one is the age factor of the patient, because most of the patients to whom we are subjecting surgery is more than 60 to 70 years old. So the complications of surgery are progressively declining from the previous 2 decades over time because of the availability of less invasive procedures. And when you look at the patient, if the patient is not a high-risk patient and if the prostate volume is less than 30 cc and the patient is not improving the conservative management, we can subject them to either TURP or transurethral incision of the prostate. In transurethral incision of the prostate, we are just cutting the capsule of the prostate alone, and so that the inward growth of the prostatic lobes are reduced, and the response is as good as TURP when the gland size is less than 30 cc. But when it is a grade 2 or more, grade 3 enlargement of the prostate, we will have to subject them to removal of the prostate gland through either a TURP, transurethral resection of the prostate, or a laser enucleation of the prostate gland. And in a grade 2, we either go ahead with TURP or laser. But in a grade 3, the gland size is more than 80 cc, which accounts for more than 40% of the case loads. We subject them to thulium laser enucleation of the prostate, because the complications of surgery is really less. The blood loss is almost 1/20th of what is seen in TURP, and early recovery is also there with laser prostate enucleation. And for other patients who are not actually fit to stop anticoagulation for at least 5 to 7 days, then for them also thulium laser enucleation can be tried, because it causes direct hemostasis with the laser treatment. So the advancement of laser treatment has actually dramatically changed the course of management of the prostate surgery. We are moving forward from the routine TURP, which is still the standard of care, to laser surgeries, and the patient complaints is really good with our experience. And if the patient cannot have any form of anesthesia, then prostatic lift or prostatic artery embolization are the two things which are in, under research, under studies, the outcome of which both have not been published yet. Now, coming to just outline of what we do in a TURP, you can see the first picture. The glandular tissue is noted as a bluish colored within the capsule of the prostate. We remove it from by lobe to lobe, and finally the complete glandular tissue is removed in a TURP. And this is a video of how to do a TURP. So we can see both the lateral lobes are grossly enlarged, and the bladder neck elevation. And what we see inside is a bladder, and this is actually the bladder mucosa, which has been replaced with collagen tissues. So we take start resection from the 6 o'clock position. We completely remove the median lobe, and then go to the 12 o'clock position and start resecting from there. And the lateral lobe resection is completed. You can very well note that with each cut there is some amount of blood loss, and at the end of a surgery, at least 1 unit of blood will be lost for a medium-sized gland if we are doing a bipolar TURP. And this is the final coagulation part which we do in a TURP. Next is a laser surgery that I've mentioned. It is the thulium laser enucleation of the prostate. In this also, we do give a Mercedes-Benz incision, which will help us to do the trilobal resection. And you can see from picture 1 to 4, the incision is given at the 12 o'clock, 4 o'clock, and 8 o'clock position. And 3 lobes of prostate are divided, separated, and each lobe is resected separately. There's a video of the thulium laser enucleation. You can see this is a separation of the median lobe. The incision is done up to the level of the root, and all the 3 lobes are separated. And you can very well notice it's absolutely bloodless. Sometimes we will not be able to go up to the capsule still. If we cut through the tissue of the prostate also, the blood loss is absolutely not there with the laser enucleation of the prostate. So this is a evolving treatment modality, which is very much safe for patients who are at high risk and safe in patients with more than 80 cc of glandular tissue. We resect the gland lobe completely and push it back into the bladder, and from there we take it through almost split. So when we look at the summary of evidence as per the EA 2022, enucleation of the prostate using Tubulin gag laser demonstrates similar efficacy compared to bipolar or monopolar transurethral enucleation, POLAR or bipolar TURP, with short, mid, and long-term efficacy. And therefore, enucleation of the prostate using Tubulin gag laser seems to be safe in patients with large prostate and those who are receiving anticoagulant or antiplatelet. With this, I conclude my talk. And whose help I'm standing here today. And we have the Tubulin laser and our volume laser, with which we do our stone and tissue resections. Thank you so much.
Thank you, Dr. The on the disease connection. The topic is open for discussion.
Complications of PRP, we can delayed complications. The most common what we come across is bladder stenosis, which can happen. The complication rate is less than 1%. Still, it can happen. Then the patient whom we are choosing, any patient we are choosing, we are choosing as selective patient. Because if the patient already has an myogenic failure, then if you clear out all obstruction, the patient cannot go there. Those kind of patients we have clinical cases, and other complications which can be seen long-term because we are inserting almost 26 instruments in the bladder. So that's also there. The incidence is less, rate less, but it can also be. Recurrence, sir, it depends on two factors. First is the completeness of the sections. So there are multiple factors where we will not be able to complete the resection. First and foremost is the health status of the patient. The patient can be a highly unsensitized patient, and he might be developing EVA syndrome during the post-surgery. And second is some prostate can bleed very much, and for these causes we may be able to do only a single lobe or dual lobe resection instead of a three-lobe resection. In these kind of patients, the unresected lobe or the partially resected lobe can be put after the surgery. After 10 years of disease, they can always present the progress. Yes, sir. Actually,
is it related to the
sir, bladder stones can be primary bladder stones, secondary bladder stones. So kidney stones usually does not have any role with the bladder outflow obstructions.
Yes, sir.
Yes, recurrent UTI are a very common finding in bladder obstruction. So it occurs as after TRP, recurrent UTI can be due to a coexisting reducer failure. The patient is not able to completely evacuate the urine, and as always, I will say subsequent the urine left and that forms also recurrent. Yeah, some patients will because tamsulosin, as per say, it reduces irritating symptoms of the bladder necrosis. Apart from what it causes, about how it acts on the smooth muscles of the prostate, the bladder also has alpha-1 receptors. So some patients with increased irritation of the bladder neck, alpha blockers are beneficial. But higher predictors inhibitors are not usually required if you have done a complete resection. Sexual function of the patient, first of all, any patient engaged on treatment with higher predictors inhibitors, they will have a decreased libido and the sexual function will be decreased. After TRP, there is no possibility of bias regarding gross decline in the sexual function. Semen emission will be drastically reduced because of the increase in it will be there. Because the bladder fibers process not with TRP, only the external sphincter will be retained. So once the semen is come to the going back to the bladder is easier route than going through the 25 centimeters urethra. So retrograde ejaculation is very common. Complications of laser surgery actually similar to TRP, we can always see bladder neck contractures and stricture urethras. Otherwise, there are no, since it is a coming up field, there are no grossly documented complications apart from what is seen in TRP. But the advantage is we can always subject the patient with high cardiac risk or high risk the patient has refractory LUTs due to bladder obstruction. Laser surgery can be taken as an option, even if not TRP. Yes. Sir, usually we find it after 5 or 6 months. Immediate post-op, it is very rare. There are multiple modalities. The strictures, if it is a bladder stenosis, we'll have to always give a bladder neck incision and focus dilatation and CIC might be required. If it is a stricture of the urethra, then if it is a short stricture in the bulbar urethra, single visual internal lymphotomy can be tried. If it is not successful, we'll have to subject the patient to substitution classes.
Many graphs. There was many graphs. Some of the and a lot of times there is
Good evening. On behalf of Kannur IMA, I express my sincere thanks to Dr. BASIL MATHEW for accepting our invitation. It was a very informative talk, especially the newer modalities of treatment and the videos. Thank you, Dr. BASIL. And I express my sincere gratitude to all members who attended this meeting. Thank you.
So the meeting is